Well, your own commissioning group was red rated on the risk assessment process, the first stage of authorisation.
Yes.
But you're planning to continue as you are. You've declined to change. Is that something that you'd encourage other commissioning groups to do, to ignore?
Absolutely. Well, no one has articulated the detail of why we are failing. Now, we do have risks and we're recognising them, and we do need support from our PCT cluster. We do need the advice of our SHA, as is SHA North, and we are going to be meeting next week with the Commissioning Development Director, and we need to have his advice and wisdom. But at this early stage of development, when we are trying to have a group of practices that have good affinity, that have a collective approach, so we're involving every single GP in every practice, we're trying to do that the same for our practice management, our nursing. So we're getting that inclusive approach. We're trying to look at the things we should be on a relatively small size, addressing at an early stage, community nursing or community services. We've already procured a new mild to moderate mental health service. We've contracted from outside of our area and gone through a procurement process as a small CCG. We're showing a small underspend, albeit in the 2 to 3% region, against the budget we've got at the moment. If we get to 4%, we've managed our QIP agenda for the first year. So we've got indicators that are saying we're moving along a good path in terms.
You can share, but what are the risks then that your particular CCG faces? Why were you red rated?
Well, part of it was on geography, and I've always said, be very wary of a clinician or a manager with a map and a pen.
Is this because you go across a local authority boundary?
No, we're in one local authority, but I think the geographic fit does cross certain wards, and for certain aspects of care that we need to address, and we will address it. For example, the unregistered population, who is responsible. In our particular area, we've got 3 CCGs, and there is some overlap, so we mustn't duplicate service. We need to understand that at the size we're at, we wouldn't be commissioning independently ambulance services or the 111 service. We need to work collaboratively, and we have every intention to do that. But for clinical behavioural change in day-to-day practice, in where we think we can make the biggest effect, and the Nuffield Trust's work on budgets recently have shown that you're probably going to make the biggest impact on patients who cost less than about £5,000 a year. You're not going to make the big impact on one big piece of heavy lifting or the individual expensive patient. Right. They are risks that need to be managed, but it's the day-to-day huge volume of work that needs to be done for those patients who are regularly using outpatients, using urgent care when they should be seeing their own practice. The things that we can affect on a day-to-day basis in small groups and work collectively is where we're focusing our efforts. Okay. But we do know if there's an individual funding request, if we've just seen the major issues around the PIP breast implants, and CCGs will be having to address that. Sure. We would not want to do that in isolation.